So, hello everyone, and wish you all the best for the results. And for all the newcomers or juniors, this is a very important session which will give you a very good in-depth knowledge of the high topics that are going to come in the future edition of the exams of FMGE. Hi all, I'm Dr. Ankit, Faculty of Anatomy at ALLENNExT, and today we are going to discuss the FMGE January 2024. Right, exam recall anatomy subject over here. We're going to have a recall of this. This recall is based on the various inputs from the students who went there and gave the exam. So let's start the session over here. Kindly note the topics. Let's start with the question number 1 over here. So here was the first question, and the question was, what is the vertebral level for the red colored plane in the image? So you can see this image is from the abdomen, and if you look carefully, then this red colored transverse plane over here is passing where at the lower margin of this we can see the costal ribs over here, right? So this is known as the subcostal plane, and as we discussed earlier on, that the subcostal plane lies where it lies around the L3 vertebrae. So answer would be L3. Now the other things as well that we need to know, what are those? Those are, if they tomorrow ask us about the transpyloric plane, which lies around the lower border of L1, remember that. Then if they ask about the umbilicus, the region of the umbilicus, it lies around which which vertebral level. Umbilicus is around L3, L4, as you can understand, L3 and L4. Then there is one more plane, the highest point of iliac crest, that is known as a supracristal plane, and that lies around L4 vertebrae. The intertubercular, which passes around the tuberosity of the iliac crest, another plane slightly below this, known as intertubercular plane, right? This intertubercular plane lies around L5 vertebrae. So remember, this vertebral level is a high topic for all your exams. So not just FMG, but even the NEET PGs or the NICT. All the topics, I am saying it again, are important for all the competitive medical exams. Let's move to the next question over here. Okay, now there will be few screenshots which you will see in the lower part of the screen over here. Those are from the screenshots taken from our various classes. Question says, identify the muscle forming the arrow marked boundary. Now this structure over here, this structure over here is very famous, known as the anatomical snuff box. It's known as the anatomical snuff box, which has a medial and a lateral boundary. Now what they asked in the exam was about this projecting tendon over here. This is forming on the medial side. So they are basically asking, what is the medial boundary of the anatomical snuff box? Medial boundary of the anatomical snuff box, you can just look carefully at this tendon. You can feel it as well in your own thumb. It is going towards the distal phalanx of the thumb on the extensor or the dorsal aspect. Now this tendon over here is extensor pollicis longus. Hence, let's first jump to the answer. The answer over here will be our option number C, extensor pollicis longus. But remember, tomorrow they may ask you about the other question. Okay, medial they have asked. Let us ask about the lateral tendons. The lateral tendons are two: abductor pollicis longus and extensor pollicis brevis. Now the screenshots over here, we have, these are from our video, the recordings in the video in our English and English part of the app. Here you can see detailed understanding of the anatomical snuff box, and all the tendons are labeled over here. Here is anatomical snuff box in detail as a complete topic. So remember, in future, if they are asking the medial boundary today, they may ask the lateral boundary tomorrow, or they may ask the structures lying at the roof, structures lying at the floor, what is the content of the anatomical snuff box. So let us quickly go through them one by one. At the roof, the main content is the superficial vein known as the cephalic vein, and there is a branch of the radial nerve. As well. In the floor, you will have the bones. Which bones over here? The lateral bones, the lateral carpal bones. What are those? Those are our scaphoid, right? Then in the proximal row is the scaphoid. In the distal row, laterally we have the trapezium. Then we have the base of the first metacarpal. Now, in the content, the only content of this whole snuff box is the artery, that is a radial artery. So remember these basic points. Questions will come from here only. I hope you marked it correct. Let us see the next question over here. Identify the arrow marked structure. Now, according to the recall, according to the students, a photo like this was given, and there was an arrow towards the lateral aspect of the wrist. Now, in the wrist, on the flexor aspect, we see normally three tendons. The tendon that is projecting, it passes superficial to the flexor retinaculum. and it continues into the, you can say, palmar part of the hand as the palmar aponeurosis. This tendon is palmaris longus. This is palmaris longus. It's superficial because it passes superficial to the flexor retinaculum. Apply common sense as well. Now, tendon lateral to it is the FCR and the tendon medial to it is the FCU. What is FCR, FCU? FCR over here is flexor carpi radialis. It is flexor carpi radialis, and FCU is flexor carpi ulnaris. Both of these tendons, what is their role? They are mainly flexors of the wrist joint. They are mainly flexors of the wrist joint. Understand this, flexion of the wrist. Now, here is a screenshot. We had discussed this, all these tendons, nerve, artery, everything in this particular slide over here. Remember, we made a mnemonic. The mnemonic over here was ALT. ALT. What is ALT? Artery is lateral to tendon. So, if I come back to this image, this is where you will have this artery. What is this artery? Radial artery. This is where we normally palpate this artery. This is the radial artery. Artery is lateral to tendon, ALT. And FCU tendon is over here, then therefore FCU tendon, then the artery which is lateral to it over here, this will be our ulnar artery. This will be the ulnar artery. Understand this part. So radial artery, ulnar artery, they are lateral to FCR and FCU tendons. Answer over here, I hope it's already clear. It is flexor carpi radialis. Right? Tomorrow if they ask you, okay, about the arrow mark tendon, which nerve supplies it? The nerve which supplies this is the median nerve. It's a median nerve. Understand this. And FCU is supplied by which nerve? FCU is supplied by the ulnar nerve. Ulnar nerve. And palmaris longus also supplied by the median nerve. Just to complete, superficialis is also superficial. But remember, it will be deep to the palmaris longus. Why? Because it passes deep to the flexor retinaculum. And the nerve supplying this is again median nerve. It is again median nerve. Okay? Right. Fine. Let's move to the next question. Which muscle is attached to the arrow marked area of the bone? So now they have given an axle over here, and the arrow is towards the bone femur, on the medial aspect of femur. Now, which important structure lies over here? That is the question. This thickened part is known as the greater trochanter. It is the greater trochanter. And where the arrow is lying, this part, a small projecting part, if you can see on this side as well, that is the lesser trochanter. This is the lesser trochanter, right? So these are the epiphyses. These are sort of, we can say, the traction epiphyses. Why? Because the tendons are attached over here and they pull this part. The muscle attached onto the lesser trochanter is the iliopsoas. It's a combination of two muscles. Ilio over here is iliacus muscle, and psoas over here is psoas major. And do remember that psoas minor also, it actually joins the major only, quite proximal when it comes out from the lumbar vertebrae. Now, at the greater trochanter, the muscles are over here are gluteus medius and minimus, not maximus, medius and minimus, not maximus, remember. Okay, so remember these basic things over here. This here we've discussed all the complete bone, all the other parts as well. They are very important parts, 3-4 things in this particular bone, like the gluteal tuberosity, quadratus femoris, then you have the medial lateral epicondyle, adductor tubercle, all that is discussed in detail. But remember, these are important things. Now, see, sir, is this a new question? No, most of the questions, let me tell you, are previous year questions, not only from FMGE. If you go through previous just 3-4 years, I'm again stressing the importance of previous year questions. Listen very carefully. Just 3 to 4 year questions of NEET PG, INI and FMGE can easily clear your FMGE exams. The only thing over here is, there are two things. First is when you're doing the question, you have to look at all the options, you look at the topic. So it's not just reading the question and looking at the answer, job half done or job 1/4 done. You have to look at all the other options, you look at the topic as well. The second thing is, after doing this research, you have to go through them again and again, at least 3-4 times revision, at least. Okay, if you do these things, then obviously the exam would be a cakewalk. But the conditions are applied over here. So over here, the answer is iliopsoas. So psoas major was the option. Here is the answer over here, the psoas major. Now tomorrow they might ask, okay, what is the nerve supply of it? What is the action of this muscle? Now psoas major or iliacus, they are mainly flexors of which joint? Of the hip joint. And which nerve supplies them? The nerve which supplies them is basically our femoral nerve. It's the femoral nerve. Femoral nerve. So remember this, right? Let's move to the next one over here. Again, you can see the screenshots. We have discussed them in very much detail. The differences of these two conditions. Identify the shown congenital anomaly in which intestine loops are present outside the abdominal cavity. Already they are giving covered by amniotic membrane. Now this itself gives us a huge hint to the answer that it is an omphalocele. It is an omphalocele. It's a congenital defect over here. What's an omphalocele? When that midgut rotation we discussed in abdomen part. When in the 10th week, when the midgut tries to come back, some part is not able to come back, and it is therefore covered by the amniotic membrane as such. That is known as omphalocele. Then what is the other thing? Gastroschisis. Gastroschisis is when there is a defect in the abdominal wall. There is a defect where in the abdominal wall. So abdominal wall is not able to completely cover the gut. So part of the gut remains outside. Let me enlarge this and show you this is a case of gastroschisis. And if it is covered by the amniotic membrane over here, it's a case of, as you can see over here, it's a case of omphalocele. Omphalocele compared to gastroschisis has somewhat poor prognosis because it is associated with other congenital anomalies. Remember that. So over here, the answer is straightforward. It's going to omphalocele. I would say that the question was easy because I already gave it is covered by amniotic membrane. So even if they are not giving this statement, you have to look at this part. Is there a membrane covering the gut? Yes, there is. So positive membrane. Answer is omphalocele. Right. Let's see the next one over here. A good question. Integrated anatomy, radio integrated. I'm not very sure, though some students said this image was given, some said this sort of image was given, whatever it is. But the concept should be clear. Question was identify the arrow marked structure. Now, if you look over here, then this yellow arrow. Now, before jumping to the answer or the options, which area it is, what you can take out from this area. See, this is the vertebrae over here. So this is the posterior aspect, that is the anterior aspect. You can look at these big organs over here. These are the two lungs over here. These are two lungs over here. Then obviously this part over here is the heart over here, Now, you know which chamber of the heart lies where. How do you know? Because we have discussed them in our anatomy lectures, in thorax, detailed heart. We'll discuss it briefly over here as well. But now where the arrow? Arrow is inside the pericardium. Where is pericardium? This over here. This, let me put some arrows. This is the PCP.C pericardium. Arrow is inside the pericardium. It is in the posterior part of pericardium. So out of the 4 chambers of heart, suppose this is the anterior view of the heart. Which chamber lies posteriorly? So you must be knowing that the chamber that lies anteriorly, this whole is right ventricle. The chamber that forms the left border is the left ventricle over here. The chamber that forms the right border is the right atrium over here. Then the chamber which lies posteriorly and forms the base of the heart. Which chamber is that? That is our left atrium, which is lying in front of esophagus. Therefore, answer over here has to be what? It has to be left atrium if the arrow is located over here. Look at this image as well on the right side. Here in this image, this will be the posterior, that will be the anterior aspect. Look at all the chambers being already labeled. This is LA for left atrium, RV anteriorly, right? And because this is a CT scan, so this is the right side, that is the left side. You can see on the left border, left ventricle, right border, right atrium, right? And these are the lungs over here. Okay, so basic anatomy, a cut section, transverse section, right? And this is how you can easily answer. Now, if you look at the other options as well, let us explore them as well. What do you think is this part? A cavity over here, which is lying where? Which is lying just in front of the vertebrae, probably more on the left side. This is the descending aorta. And in front of it, you can see that this part might be esophagus over here. And right in front of esophagus lies the left atrium. How to revise this? Now, in medicine also, you learn about a valvular defect in heart, that is MS, mitral stenosis. What happens in mitral stenosis is the mitral valve, which connects the left atrium to left ventricle, is stenosed. Now, this will dilate the left atrium. It will lead to left atrial dilatation. Now, when the left atrium is dilated, it is going to compress which structure? The structure which lies behind it and is easily compressible. So what is that compressible structure behind the left atrium? You can understand it is esophagus. So patient of MS, mitral stenosis, might present with, if the esophagus is compressed, might present with the dysphagia. Okay, so that we used to read in our clinical aspects in medicine. So, okay, so this was the question over here, and good question. Let's see the next one. Again, a high topic about the lumbar puncture. In this time, they asked about the epidural procedure. Now, during the epidural procedure, they are asking all these structures are pierced except epidural. Now, see what happens is you should know basics. Even if you are confused with the options, basics are always there. What are the basics? Basics is we have a bone outside. Like the vertebrae over here. Inside the vertebrae, we have the vertebral canal, which is housing what? Which is housing the meninges also. Here you have the meninges, right? Let us name them as meninges. Now, in meninges, we should be knowing that from outside to inside, there is dura, then arachnoid, then pyometer. This is a very basic thing that we should be knowing. There are three layers. Most outside is dura mater, then arachnoid matter, then pia mater. Now they are asking you during an epidural procedure. Now if I zoom it, epidural means outside the dura. Epidural means this area between the dura or located superficial to dura. So this, imagine it is the epidural space. So the needle has to enter at this space. Now they are saying which structure will not be pierced. Let us see the options. Interspinous, supraspinous, ligamentum flavum, subarachnoid space. Now subarachnoid space obviously is where subarachnoid space is deep to arachnoid. Where it would be, this green color, understand this area. This is the subarachnoid space. So over here this is subarachnoid. What is the content of subarachnoid space? Subarachnoid space houses the cerebrospinal fluid. So obviously if the needle is coming from behind, from posterior, then obviously it will enter through the various ligaments, skin, fascia, and then it will enter through the dura mater, and then it, or not the dura mater, just before dura mater it will stop. It won't pierce the dura mater also. So therefore answer over here is what? Subarachnoid space. This is common sense. Now look at the image below. If you look at the image below, what do we realize? Here you can see this is the posterior aspect, that is the anterior aspect. Look at these spaces. Look at this subarachnoid space over here, and look at this epidural space over here. And then also look at this whole skin, subcutaneous layer, muscles, supraspinous, interspinous, ligamentum flavum. All these are pierced. Then the needle will enter the epidural space. Now, if you have to do a lumbar puncture, then you have to enter CSF. Then you have to enter subarachnoid space. In that case, your needle will enter through the dura and arachnoid, then it will enter subarachnoid. So if the question comes about the subarachnoid space, then obviously you have to enter this area, you have to pierce the dura mater. But in this epidural procedure, the dura mater is not pierced. You are going superficial to dura mater. Right? So remember this point. Answer is our option number D over here. Good question. Let us see the next one. Identify the type of arrow marked joint, or identify the joint marked by the arrow. So obviously we can understand that this is an image from the X-ray of a hand, right? This is the thumb over here, or this is the radius over here. This is the lateral side, that is the medial side. This is ulna over here. Then we have 8 carpals. If I just try to show you, this must be the scaphoid, lunate, triquetral, pisiform. Then you have the trapezium, trapezoid, a big capitate, and a hamate. Remember the mnemonic, she looks too pretty, try to catch her. So you have arrow is where? Arrow is between the trapezium over here, and this is what? This is the first metacarpal. So which joint is this? This is first carpo-metacarpal joint. And this is what makes the thumb different from other 4 fingers. You can understand the movement of the thumb. So many muscles over here, the thenar eminence, different from the other fingers. So this joint is first carpo-metacarpal, and it allows thumb to move in all the directions. Therefore, logically also, this joint must be very much mobile. And yes, it is. It is a multi-axial joint. It is a multi-axial, means movement can occur in various axes. And there are basically 2 varieties of multi-axial. One is the ball and socket, example we all know, shoulder hip. And one is the saddle variety, which is this one. So this over here, the first CMC is an example of saddle joint. So saddle. Other example of saddle is what? Sternoclavicular joint. Remember this, sternoclavicular joint. Other example of saddle is in the tarsals also, between calcaneum and cuboid. So calcaneo-cuboid joint. Calcaneo-cuboid joint. You can see in the screenshot over here, we are discussing this carpal and the first metacarpal and saddle variety, first CMC over here. Because remember, it's a topics that will be repeated. I told you previous year questions, pick up them. 3 to 4 years is sufficient. And the most important topic in general anatomy is the topic of joints. One question normally comes from this topic. Just some simple questions. Okay, let's move to the next one over here. Okay, identify the organs. CT, always remember, in a CT, when you're looking at a CT, then understand that the person is lying like this, head and over here, neck and this, trunk and lower limb like this. Person is lying down on a bed. And you are seeing from here, you are visualizing from here. So if you take sections like these, understand that this is the right side, that is the left side, that is anterior, that is posterior. You are looking from the foot end of the patient. The patient is lying down, supine. This thing remember. Now, if you look over here, then they have asked what is 1, 2 and 3. What is this 1, 2 and 3 over here? If you just look over here, then this is labeled as number 1. This is over here is labeled as number 2, and this is labeled as number 3 over here. I'm sure there won't be much of a doubt to identify 1 as liver on the right side, and 3 over here, it is the spleen over here, just in front of the ribs. Remember, there's a rib fracture on the left side, 9th, 10th, 11th rib on the left posterior aspect. Chances are the spleen could be damaged. And this structure over here too is in front of these major vessels. Now, what are these major vessels? Let me tell you. This vessel over here is in front of vertebrae to the right side. This might be IVC. Then this will be our aorta. Aorta is towards the left side. And therefore, this structure, number 2, is a retroperitoneal structure. Probably it is pancreas. Now, if you look at the options over here, if the options were in this way, they were very simple. Why? Because number 1 is liver only in one of these 4 options. Then you can easily 1 liver, 2 pancreas, 3 spleen. Simple as that. And here's a detailed labeled image over here showing us all these things. The liver over here, the SP for spleen over here, right? This is your pancreatic head over here, PH is pancreatic head over here, and other structures, IVC, aorta, K for kidney over here, GB for gallbladder over here. All these things are already gone. Go through them. Okay, so over here the answer was option number C. Coming to the next one, the common carotid artery is felt against C6 tubercle at what location? They're already saying C6. Again, the topic is vertebral levels. Now, C6 we all know is a location of cricoid cartilage. Sir, where is cricoid cartilage? I told you mnemonic also, HTC. If you go from superior to inferior, H is the hyoid bone, T is the thyroid cartilage, not the gland, the cartilage, and C will be the cricoid cartilage. And this cricoid cartilage lies at around C6. So if you look over here, then imagine this is the arch of aorta. Okay, this is a brachiocephalic trunk, right subclavian, right common carotid. This is left common carotid and left subclavian. Let me just quickly label it as well. This is arch, that is right subclavian. This is left side subclavian. This is LCC, left common carotid, RCC, right common carotid over here. Now, where does this arch of aorta lies? Arch of aorta lies behind the manubrium of sternum. This is the manubrium of sternum. Okay, so we can understand that this area over here is the suprasternal notch. What is this? Suprasternal notch, which you can easily feel as well. Look at our videos on the clinical videos, anatomical landmarks. This suprasternal notch over here. And here this level over here, we can say suprasternal notch. It lies at which vertebral level? It lies between T2, T3. Okay, so you have T1 over here. Above T1 you will have C7 and you will have then C6. At the level of C6, what we have this cricoid cartilage, arch and lamina behind. And then if you go superior to it, you will have this thyroid cartilage with the Adam's apple over here, thyroid cartilage, huge thyroid cartilage, and above it again you will have this small hyoid bone. And this common carotid artery, it will keep on going, and then what happens is at the upper border of thyroid cartilage, it bifurcates into external and internal carotid artery. So common carotid artery is from where to where? It is from here to here, and then they're asking C6. Undoubtedly, it is the arch of cricoid cartilage without any doubt. Without any doubt, it has to be the arch of cricoid cartilage. Let me just change the color over here. Here we go. Arch of cricoid cartilage. If you look at the other options also, laryngeal prominence is nothing but that Adam's apple over here. But that is not C6. Suprasternal notch, I already told you, it is around T2, T3, just above the manubrium sterni. An angle of mandible is quite higher up over here. It will be around, say, C2. Okay. So therefore, answer is arch of cricoid cartilage. Let's see the next one. Again, the question from the topic is pharyngeal arches. Topic over here is pharyngeal arches. Very important topic. Arrow marked structure. Now you can see the arrow over here. It's from an otoscope, you are looking at a ear ossicles. And probably it is the malleus and incus. This must be the malleus, this must be the incus. Stapes is more medial. And look at this image over here that we have discussed in our subsequent videos. Beautifully color coded. This orange color is the first arch, which includes malleus and incus. This blue color is the second arch, include stapes. Then you have third, fourth, and sixth arch. For our third arch, mainly for the hyoid bone, fourth and sixth for the laryngeal cartilages. These are fourth and sixth. This is the third over here. So now we are pointing out towards the incus. It is the first arch, and therefore there has to be an option. First pharyngeal arch is the option, right? So 2 out of 3 ear ossicles, they come from the first pharyngeal arch, which also give rise to the whole mandible over here, known as Meckel's cartilage. Okay, so again, basic embryology, head neck embryology. Okay, let's see next one, again related to the pharyngeal arches topic. Again, see how important is this pharyngeal arch topic. Keep on noting down the topic. Don't just watch videos for fun. Okay, I've seen the videos, fine. No, that's time wastage. Copy pen lo, notes likho. If you not the complete note, at least topics likho and see whether you know the topics or not. Then go to the videos. Dekho some topic samjhaya gaya. And if you want to integrate. All subjects ke videos bhi dekhiye. If you want to integrate it. So that is very important. That is a use of time. Now coming to the question, the arrow marked congenital anomaly develops due to non-fusion of. Now what is this anomaly? In front of here, we have this over here that would be a preauricular sinus. It could be a preauricular sinus. Preauricular sinus, and they are asking about the pharyngeal arches or pharyngeal pouches. Now we all know, if you look at this coronal section, that the pouches are lying on the inside and they are giving rise to the endodermal structure. Outside what we have these as the pharyngeal, or you can say clefts over here, which are coming basically from the ectoderm over here. Now this structure over here is lying inside or outside? Is lying more inside. Now this structure is the auricle. If we know that auricle is coming from which arch, things are easier. Let us see over here. I'm just zooming it and for you guys to understand. This is the first arch, that is the second arch, this is third, that is fourth, and this will be the sixth arch. Fine. Now if I put a green arrow over here, this is the middle ear, M dot E dot. Therefore this one over here is the external auditory meatus. Now if you have seen the external auditory meatus, you know this is the area for the auricle. So this auricle is coming from where? First and second arches. So therefore, when the pinna or the auricle development is first and second arch, then obviously this preauricular sinus is coming from first and second arch, not the pouch. Because pouch gives rise to different structures. Answer over here is first and second arch. And what does the pouch give rise to? The first pouch, if I just quote over here, first pouch gives rise to, as you've seen, the middle ear. Also, you can say the eustachian tube as well. Okay, the second pouch will give rise to what? The tonsillar fossa, where you have the palatine tonsils located, epithelium of the palatine tonsils. Third pouch gives rise to other structures as well, as you can see in this particular image. Topic, remember, is pharyngeal arches. Answer over here is first and second pharyngeal arch, not the pouches. Here is the complete table of the development of ear. This is what this development of ear. Let me just boil down over here, come at the last point. Auricular hillux, dorsal end of first and second arch forms the auricle over here. This is the complete development of ear. If you correlate this table with this image over here, things will be crystal clear. Okay, here you can see malleus incus, pharyngeal arch. So with this table, 2 questions came. Right, stapes, second arch. Pharyngeal pouch 1 and 2, middle ear of this auditory tube, mastoid antrum, membrane are different. They are where the pouches and cleft meet. All the 3 germ layers, tympanic membrane, this used to come when we used to give the exam. This was a very important question. And finally, groove 1 is external auditory meatus, or the cleft one. Let's see the next one. A patient understands everything and is able to identify an object, so understanding everything, but he is unable to tell the name of the object, not able to create words, known as a non-fluent. This is sufficient. If they have given the non-fluent aphasia, it means the patient is not able to form the words. Is it a motor or a sensory problem? Sensory problem is when the patient is unable to understand. Now he is able to understand everything. So sensory is okay, but motor is a problem, motor aphasia. Also known as non-fluent aphasia. That comes from the Broca's area. Broca's, what is Broca's area? These are few areas in the brain, mainly in the dominant hemisphere or the left hemisphere. So in the left hemisphere, you have a Broca's area. Where is that? You know the frontal lobe. It lies at the inferior frontal gyrus. Inferior frontal gyrus is where the Broca's area is located. With a Broadbent number, I am telling everything because the next exam, the question might be different. Broadbent number is 4445. Remember this. This we have discussed immensely in our lectures. Go through them. We have discussed the whole table, difference between the Broca's and the Wernicke's. This is the area and this is 4445. You have the Broca's area. And then area number 22 is the Wernicke's area. We have the sensory aphasia at that part. where the patient is unable to understand. That is Wernicke's. So here, this is the job of Wernicke's area. This is the job of Broca's area. So obviously, answer over here will be Broca's. Okay, will be the Broca's over here. Let's see the next one. Now, again, question is from the development embryology question of diaphragm. Diaphragm development. We'll see it. So they are asking the dorsal mesentery of esophagus forms which component of the diaphragm? See, diaphragm is formed from 4 components. How many components? 4 components. We have septum transversum as option A. Then we have pleuroperitoneal membrane as option C. Then we have the dorsal mesentery of esophagus. And finally, we have the cervical somites. Why cervical? Because the diaphragm in the initial phase of development lies close to the neck. Therefore, the nerve supply of diaphragm is the phrenic nerve with the root value C3, C4, C5. Remember that. Now, dorsal mesentery of esophagus will form what? First of all, it is from esophagus and that is passing dorsally behind. Now, if you look over here in this image, then you will understand that this is the posterior aspect, that is the anterior aspect. Most of the central tendon part of the diaphragm comes from the septum transversum. Then these pleuroperitoneal membranes over here, they will form the small posterior lateral part of the muscular part of diaphragm. But now you can see over here, this is the esophagus. Let me highlight, this is the esophagus over here, this area. And therefore, it is the dorsal mesentery of esophagus will obviously go behind. And they will form the part of diaphragm which lies posteriorly. Now, which structure lies posteriorly in the diaphragm? It is the crus. So, what are crus? Crus are the attachments of diaphragm to the lumbar vertebrae. You can see the vertebrae over here. Crus are attachments of the diaphragm to the lumbar vertebrae. There is the right and the left crus. The right crus goes up till L3, the left crus goes up till L2. These were the questions that we used to come in the past. So, the crus over here is located posteriorly. Therefore, the dorsal mesentery esophagus giving rise to the crus. Remember that part. Okay. So, this topic again important, development of diaphragm. Let's see the next one. Again, the topic inguinal canal again and from the anteabdominal wall. Now, for the conjoint tendon, all are true except what is false about the conjoint tendon. Now, before going to the options, let me clear a few points over here. Conjoint tendon is a junction of 2 tendons, muscle of 2 tendons. One is internal oblique, inferior is for the extraocular muscles, internal oblique and transverse abdominis. They are tendons, they form conjoint tendon. Also do remember the conjoint tendon, it mainly forms the roof of the inguinal canal anatomy, but it will also go anterior wall as well as posterior wall. So suppose this is the inguinal canal, this conjoint tendon forms the roof, but then it goes anteriorly as well as some part posterior. So it does not form the entire anterior or the entire posterior wall, no. It forms a part of the anterior wall, part of the posterior wall. Okay, but it will go anterior posteriorly and mainly it forms the roof of the inguinal canal anatomy. Okay, now let's see the options. All are true except formed by the internal oblique and transverse abdominis. Yes, correct. Protects the superficial ring to maintain. Yes, it is actually behind the superficial ring and it is anterior to deep ring. It is anterior to deep ring. This conjoint tendon is behind the superficial ring, supporting the superficial ring from posterior aspect. And it is just in front of deep ring to protect the deep ring from the anterior aspect. This is, this 3-way function of the conjoint tendon. So this statement is correct. Forms the posterior, as I told you, it forms a part of the, not the entire. If they would have said forms the entire posterior wall, that would have been wrong statement. The entire posterior wall is formed by which structure? It is formed by the fascia transversalis. Fascia transversalis, entire posterior wall. And the entire anterior wall formed by the external oblique epineurossus. You can see in the screenshots, we discuss them in much detail. But obviously, last statement is wrong. They are saying it does not run parallel to the inguinal ligament. It is also known as, what is the other name of conjoint tendon? Anyone? What is the name of conjoint tendon? In the comment box you can write. Other name, synonym. It is sickle shaped, we call it as fox. Lies in the inguinal region, we call it as fox inguinalis. This is the other name of conjoint tendon. You can see the screenshot, but let's see over here. These are the 2 tendons. The internal oblique and the transverse abdominis, they are going to form the conjoint tendon. Now you can also see that it is lying in front of the deep ring and it lies behind the superficial ring. And obviously it is going above the canal, forming the roof of it. A very important topic. Okay, another embryology question. The following anomaly. Now, looking at the image over here, many times we have discussed that. Look at the images of embryo. If you have less time, at least go through the images. This is a case of where the brain is actually coming out of the skull, not fully formed. It is a case of anencephaly. It is a neural tube defect, and it is a defect of the or cranial or the caudal neuropore. Obviously, the cranial neuropore. Caudal is lying at the lower end of spinal cord. It is a defect of the cranial neuropore. Now, look at the options. The following anomaly: failure of closure of cranial neuropore at week 4. Okay, this is fine, but is it week 4? Yes. How? See, the neural tube neurulation forms at week 3. Then in this neural tube, you have this as the cranial and the cranial neuropore, and this is the caudal and the caudal neuropore. This cranial neuropore over here, it starts to close on which day? Day 25. Day 25 is week 4. And this caudal neuropore starts to end at day 28. That is again the end of week 4. So therefore, option number A, statement number A is perfectly right. Let us see other options. Failure of closure of neural tube, no. This is not a whole closure of neural tube because tube will remain the tube. Failure of closure of neural tube, at week 3, the neural tube has started to form neurulation. No. If the caudal neuropore is having any defect, we will call it as spina bifida. We will call it as spina bifida. There's again a screenshot explaining in detail, but just go through the lectures, you will get these. Okay, so this is anencephaly. Next question, probably the last question. Let's see. Again, embryology. Embryology came a lot. Histology, I don't think any questions came from histology, but that's by chance. Now they're asking you which part of placenta is attached to maternal side. Simple question. Do you know the anatomy of placenta? Placenta is where the exchange of food, exchange of waste material, exchange of gases is taking place between the mother and the fetus. So it has to be formed from both the fetal side as well as the mother or the maternal side. The fetal side is the one who is receiving all the nutrients. It forms villi. They are known as chorionic villi because they are formed from chorion. Chorion is our trophoblast. And that part of the chorionic villi which forms the placenta is known as chorionic frondosum. Remember this word. Now, from the maternal aspect, what is happening is the whole this implantation, the whole embryology is occurring in the uterus. So it is occurring at the end of uterus. Now, in the uterus, when the uterus becomes pregnant, this is known as decidua. And that part of the uterus where the chorionic frondosum will enter is known as decidua basalis. Decidua basalis over here. So it is a combination of chorionic frondosum and decidua basalis which is forming the placenta. Technically, this is. And the image below you can see over here the decidua basalis from the mother side, and over here you can also see this chorion which is entering. Okay, and there the transfusion takes place, forms a hemochorionic placenta. Therefore, this is the maternal side is decidua basalis. This is the decidua basalis. Now, capsularis and parietalis are different. Capsularis is the other part which is in touch with the embryo, but not in touch with the chorionic frondosum. While parietalis is all the other part of the uterus, all the complete except where the implantation is occurring. The other remaining all the uterus is decidua parietalis. Answer over here is decidua basalis. Right. So guys, this was the recall. I hope you enjoyed, and all the best for the result. I am sure that at least 70-80% questions you must have been tick marked correct if you have been revising it, because all the questions either came from previous year questions or previous year topics, high topics. No question over there was something like that. It came some out of the blue. We have no idea about it. I don't think that was the case. And for all the other future students, please note down all the important topics over here. They are very, very high. That's all from my side. All the best. Thank you.